பசுபதி இன்னைக்கு உடம்பு சரியில்லை, அழகர் எல்லாம் ரெடி பண்ணி வச்சிருக்கிறோம்.
அந்த கேசட் ரெடியாக இருக்குங்க.
ஓட்டி ஃபைல் எல்லாம் ரெடியாக இருக்கும்.
சரி, உள்ள போட்டு பாருங்க.
பார்த்துருங்க, இல்லைன்னா
மோஸ்ட்லி இது சரியா போயிடும்.
இன்னும் எடுத்து வச்சிருக்கிறோம் வீடியோ.
சரி சரி. எனக்கு தெரிஞ்சதை கொட்டு எழுதுன்னு
அந்த உண்மை தான் தெரியும்.
சரி, நீ பாருங்க விடுறோம்.
ஹலோ, கீழே இந்த ஆடிட்டோரியத்தில் இருக்கிற சிஸ்டத்தில் நெட் வரும்ல? இப்போ அதில் இந்த இன்னைக்கு அந்த ஏதோ நாங்கள் யாரும் போன தடவை போட்டால் யாரும் பார்க்கல. அந்த ஸ்ட்ரீமிங் பார்க்கணுன்னாங்க. பட் இங்கேருந்து கீழே வந்துட்டு இருக்குது. அதை நீளமான பேட்ச் கார்டு நீளமாக வச்சுருக்கிறீங்களா அங்கேருந்து போடுற மாதிரி? இன்னைக்கு பசுவதி இல்லை, அதனால இருந்தால் நம்ம அந்த பாக்ஸ்குள்ள ஒரு இது வச்சிருக்கிறோம்ல, அன்னைக்கு 2 இது போட்டிருந்தோம். பட் உள்ள எடுத்து வீடியோ கான்ஃபரன்ஸு கனெக்ட் பண்ணோம்ல, சுவிட்சை எடுத்துட்டு வந்தாச்சு. இல்லைன்னா அது மாற்றிக்கலாம். சரி, நீங்கள் சாப்பிட்றீங்களா? கேபிள் மட்டும் நீளமாக ரெடி பண்ணுங்க, நான் வர்றேன். அந்த சிஸ்டத்தில் வைஃபை எடுக்குமா? ஏதோ என்ன நம்ம அந்த ஆன் பண்ணாலே வைஃபை வந்துடும்ங்க. ஆமாம், இல்லைன்னா யாராவது ஒருத்தர் சிஸ்டத்தை கொண்டு வருது. ஒரு லேப்டாப் எங்கேயாவது கொண்டு வந்து வச்சு அந்த மாதிரி பண்ணி விட்ருங்க. அப்புறம் நீங்கள் அந்த ஆடியோ ஒன்று கொடுக்கணும். ஆடியோவுக்கு வந்து அந்த லேப்டாப்போ சிஸ்டத்தில் ஸ்பீக்கர் அவுட் எடுத்து அந்த உள்ள அதுக்கு வால்யூம் கொடுக்கணும். அது லேப்டாப் கிடைச்சா அந்த மாதிரி பண்ணிக்கோங்க. இல்லைன்னா கேபிள் ரெடி பண்ணுங்க. அந்த இதுக்கு நான் வந்து போட்டுத்தரேன். அதுவும் நம்ம 4 மணி நேரத்துக்குள்ளே பண்ணிங்கன்னா தான். அதுக்கப்புறம் முடியாது. அதுக்கப்புறம்னா நீங்கள் வைஃபைல யாருக்கையாவது சிஸ்டம் வாங்கி மாட்டிருக்கேன். ஹலோ. அந்த ஆடிட்டோரியத்தில் ஒரு நெட்டு கொடுக்கணும். இல்லை, அது வந்துடும். நீங்கள் அது பிரச்சனை இல்லை. கீழே வந்து நெட்டு கொடுக்கணும் அந்த சிஸ்டத்துக்கு. வைஃபை அந்த சிஸ்டத்தில் எடுக்குதா? அப்போ எடுக்குதுன்னாக்கா நீங்களே ஒரு லாகின் பண்ணிக்கலாம். டெலிவரி ஆஃபீஸ் போயிட்டு அது மாதிரி போயிட்டாக்கா அதை கொடுத்துட்டு குணசார்கிட்ட அந்த ஆடியோ மட்டும் எடுத்து கொடுக்க சொல்லியிருக்கிறேன். அது பண்ணி விட்டுருக்கோம். ஓகே. இதில் பார்க்குறதுக்கு இது ஸ்ட்ரீமிங்கில் லாக் பண்ணிக்க வேண்டியதானே. இதில் ஒன்று இப்போ முதல்ல ஏதோ 10 பேருக்கு அனுப்பி வச்சுறாங்க. அது அதுக்கு
ஆக்சுவலாக இதெல்லாம் க்ளோஸ் பண்ணி வச்சுருவாங்க சார்.
அந்த இவங்களுக்கு அந்த இந்த லிங்க் கொடுக்குறேன்னு சொன்னீங்களா வெங்கடேஷ்கிட்ட ஆடிட்டோரியத்தில்? அது டெலிவரிக்கு யாருக்கு தானே? சரி, நீங்கள் கூட இதை ஏதாவது கொடுத்துருக்கீங்களான்னு நினைப்பேன். முதல்லயே அங்கே 10 பேர் போட்டு வச்சுருக்குறாங்க. சரி சரி.
அங்கே பெட்டராக இருக்குமா? இல்லாட்டி அங்கே பெட்டராக இருக்குமா? ரூம் நம்பர் 1 அங்கே எடுத்துகிட்டு போகிறீங்களா? அங்கே வரட்டா இல்லாட்டி? கனெக்ஷன் லாஸ்ட்னு வருது. அங்கேயே வந்துடும். வேறு ஏதாவது ஒழுங்காக இருக்கு.
ஓகே.
Good afternoon, Venkatachalam sir. Parthu, good afternoon.
Hello. Hey, Roshan.
Good afternoon, sir.
Yeah. Okay. Hey, Roshan, you are.
Yes, sir.
You are only connected now. Huh?
Only Varghese sir has got connected, sir.
Yeah. Whoever is not there, you can say they will be connecting later. Don't say.
Yeah, that I'll tell, sir. All the foreign faculty I'll do like that only.
How's the clarity is coming? Okay.
Clarity is good, sir. And Parsarthi and Venkatachalam sir have incorporated that same technology of writing on the screen.
He has got it, but whether we are doing it today or not, we do.
Oh, I see. Okay.
Hello.
Sir, good afternoon, sir. Dr. Vijay Kumar sir is online, sir.
Yeah, you asked me to join 255, but I joined 253. Sorry about that.
Hi, Vijay Kumar. How are you?
Sir, how are you, sir?
All fine.
I'm unable to see your face.
It's not coming. Oh, I will go to my face only will come inside OT. So I have to go inside.
Good afternoon, Dr. Varghese.
Yeah, good evening, sir. Good afternoon.
How are you?
Fine, sir.
Varghese, that stapler is still not at reach. And he says he will be getting it. Probably somebody will bring it. Let us see. Then
Yes, sir.
Sir, good afternoon, sir.
Dr. Ayappan.
Good afternoon, sir.
Good afternoon, Dr. Ayappan.
Good afternoon, Professor Ayappan. How are you?
Sir, I'm fine, sir. Thank you, sir.
No, nice to see you with
cap
and mask, etc., to say that you are very busy in the OT and joining.
Thank you, sir. Your students, sir. We should be busy, sir.
Yeah, naturally.
Yes, sir.
So I think cap remove பண்ணிட்டாங்க sir. It looks little bit கொஞ்சம் old மாதிரி இருக்காருங்க sir.
Ayappan, Pastor says remove your cap. Otherwise, it looks older than Vijay Kumar.
Thank you, sir.
Okay, I will go. I will get ready.
Thank you. நான் இதை correct.
உள்ள லேப்டாப்
What is the plan today, Dr. Roshan? Today, now?
Sir, now we'll start with the introduction of the program, and then President Dr. Varghese will say a few words.
Yeah.
And then Palanivelu sir will speak a few words, and then we'll introduce all the faculty who are moderating today. And then 1 minute for the sponsorer for our pharma support for us, Merrill Endosurgery. They will speak for a minute. And then we'll move on to the live surgery, sir. So you can interact with Palanivelu sir directly. All the audience or the delegates will, their questions will be put on the side chat. So you can see and
everything. Every question will be taken by Professor Ayyappan, obviously. No?
Sir, you are in full mood for. Thank you, sir. Anyway.
Full mood at 3 o'clock also. If you cannot come in mood, what is it? I finished my all office work and I'm waiting for this 3 o'clock now.
Thank you, sir.
Roshan Shetty told me in the morning, sir, 2:55 you have to join. I told him I'll join in 2:53.
So better you handle Ayyappan sir rather than me.
Please, all of you don't escape. Some of you should be there.
See, please understand, in surgical gastroenterology, rectal examination is a part of the clinical examination.
Primary. But today we are doing gastrectomy, so I don't think so you can put a finger into the mouth now.
Jay Kumar sir, everything is.
That's all. See, gastrectomy to be done, whether blummer shelf is or not there, I have to see.
I was waiting for this. Whether you put your finger there or not, you should have examined. The most important thing when it comes to the gastrectomy is to have clinically examined to see whether there are any nodules in the commercial. That's all.
Correct.
Yeah, we are ready. Thank you. Professor Varghese should not go mad the way we are talking.
No, sir, enjoying. Ayyappan.
Yes, sir.
After a long time meeting.
Yes. But today, anyway, you are going to be there, but he will not bully anybody. He will bully me only now.
No, don't worry. I will not bully anybody. I told you, I have already given the statement. All answers will be given by you. Let me see as a moderator and arbitrator whether you are giving proper answer.
Sir, you should only answer, sir. You have the thing, sir. We'll just wait and see what the teacher has to say, sir. But anyway, yeah, we both know the answer will be given by only one person, sir.
At that time,
yeah, that's all.
Chintan, welcome.
Yeah, thank you. Thank you so much, sir.
Okay. Some of faculty is yet to join, but anyway, since it's almost going to be 3 o'clock, I'll just check whether Palanivelu sir is ready in the OT.
Roshan, this is Dr. Varghese. Sir is getting ready. Meanwhile, if you are, we can. I think we can start the
introduction.
With the introduction of case.
Okay.
And then Chetan also, you want to talk? No, after Sir Varghese sir introduction, he can talk.
Yeah.
Then we'll go for surgery. Yeah?
Okay. Then I'll count on 1, 2, 3 or 3, 2, 1. So then you can go live.
Decide 1, 3, 2, 1 or 1, 2, 3.
3, 2, 1.
Live.
Arthur, can I go ahead?
Yeah, already is live, Roshan. This program is just started live.
Okay.
Yeah, you can. I think I asked Sangar to present. You can start. Yeah, you can start.
Yeah. Good afternoon, dear friends. Also, we have a galaxy of luminaries here who will share their knowledge with us during the 7th edition of AMASI Lens, initiative of AMASI to relay online live surgeries to all the delegates all over the world. So, without wasting much time, I request our president, Dr. C.J. Varghese, to address the gathering.
Thank you, Dr. Roshan, and welcome everybody to the AMASI Lens, the online surgery, laparoscopic surgery demonstration program of AMASI. In fact, AMASI is doing 2 online programs, one CME program every first Thursday at 8 p.m. and this operative surgery, live surgery program on every third Thursday between 3 p.m. to 6 p.m. And in fact, for this program, Palanivelu sir himself is taking so much interest, and this program is going on very well. And as Roshan mentioned, this 7th program we are doing, and this year the first program. And this January onwards, we are actually being supported by Merrill Endosurgery. And Mr. Chintan, the national head of the Merrill, is here with us. And we are actually thankful to Merrill for the support that they are giving for AMASI Lens program. Over to Dr. Roshan.
Thank you, sir. I think our founder president, Professor Palanivelu, will speak later during the course of the procedure. Meanwhile, I would like to introduce the faculty who are the expert panelists today. Some of them are yet to join, but they will join shortly. First and foremost will be Dr. Woo Hyung Jin from Seoul, South Korea. And then we have Dr. Peter Orwald from Madrid, Spain. And we also have Dr. Enquista from Netherlands. And among the Indian luminaries, we have Professor Vijay Kumar sir, who needs no introduction, very good supporter and guide to me. Professor Vijay Kumar is the Vice Chancellor of Yanapaya University, a well-known oncosurgeon and a former director of Kiba Institute of Oncology at Bangalore. I welcome you, sir.
Thank you.
We have Professor Ayappan, who's a senior consultant and head of the Department of Surgical Oncology at Apollo Cancer Hospital, Chennai. He is also the secretary of Tamil Nadu Association of Surgical Oncologists. He is a well-known robotic and laparoscopic oncosurgeon from Chennai. Welcome, sir.
Thank you.
We will be shortly joined by Dr. P.K. Das, who is a surgical oncologist and dean of Utkal Multispeciality Hospital, Bhubaneswar. He is the immediate past president of IASO, that is Indian Association of Surgical Oncologists, and also a former HOD Surgical Oncology at RCC, Cuttack. I welcome him. We also have Dr. Baiju Senadipan, who is the chairman and MD of Royal Sims Research Center, Trivandrum. He is also a senior consultant GI surgeon at Trivandrum. He is a well-known person in terms of online programs he has been conducting from last couple of years. Post-COVID, he has had numerous interactions through CME to all the delegates. He is one of the pioneers in mastering this kind of programs. I welcome him. We also have our own dear friend, Dr. Arsarthi, who is the CEO of GEM Hospital, Coimbatore. He is also the chief and lead surgeon for focus surgeries at GEM Hospital, Coimbatore, and also the technical director of AMASI, and he's also the convener for this particular program. I welcome him as well. And let's not waste much time. And then I request our pharma support, Ms. Chintan, who's from Merrill Endosurgery, to say a few words.
Yeah, thank you so much. Good afternoon, respected delegates and faculties. My name is Chintan Gajjar. I head the marketing of Merrill Endosurgery. First of all, I would like to thank entire AMASI, Dr. CJ Varghese, Dr. Padasati, and Dr. Palanivelu sir for giving this great opportunity to collaborate with AMASI Lens and in this professional educational journey. So yes, just a short message from my side that yeah, we believe in professional education, and we run a lot of programs at our own Merrill Academy at WAPI as well as outside Academy, and we will continue such kind of professional educational journey in across the specialty in general surgery, GI surgery, onco-surgery. Yes, I thank AMASI and the entire board for supporting Merrill and endorsing most of our events inside Academy and outside Academy. So thank you so much, respected faculties, organizing committee, Dr. CJ Varghese, Padasati sir, and Dr. Palanivelu sir. Thank you, and looking forward for long-term association with this professional educational journey, sir. Thank you so much.
Thank you, Chintan. We are really appreciative of your support. And now, without wasting much time, I leave the floor to Professor Palanivelu to interact with the luminaries that are present here, and maybe we'll have a wonderful program. Thank you very much. Over to Professor Palanivelu, sir. I think somebody speaking about the
Yes.
case, or should I
Yes,
speak?
Roshan. Yeah. Sankar, you can start present the case.
Hello, Partha. Nice to hear your voice, though I am unable to see you.
Yeah, good afternoon, sir. I'm going inside, sir, inside the OT. I think I'm in a control room now. They are not started. I'm going inside, sir. 1 minute.
I think
I am
Shankar
seeing
can
Professor,
with the history
I am
of the
seeing
patient.
Professor P.K. Das joining.
Yeah.
Good evening. I'm Dr. P.K. Das. Hi, how are you all?
Just before you could join, Dr. Roshan Shetty has introduced you, sir, a few minutes back. Welcome, sir.
Okay, thank
Welcome,
you.
sir.
Thank you.
Hello.
Yeah.
Sir, can you hear me?
Yeah, Shankar, tell me.
Yeah.
Good afternoon, sir. A brief history about the case.
Yeah.
It's a 74-year-old gentleman with no known comorbidities, presented with dysphagia for solids for 4 months, associated with loss of weight of about 6 kg in 2 months. Patient was diagnosed with adenocarcinoma of the OG junction extending into the stomach, and he received 3 cycles of neoadjuvant chemotherapy and completed it in December 27. And on examination at present, his BMI is 14.3. Per abdomen, it's soft, it's unremarkable. His investigations, hemoglobin is 11.5, albumin of 3.7. Other routine blood investigations were normal. And upper GI endoscopy post neoadjuvant therapy showed residual proliferative growth at OG junction extending into the cardia and fundus of the stomach. The biopsy was poorly differentiated adenocarcinoma. This is the post neoadjuvant therapy endoscopy showing the presence of the growth near the OG junction extending into the greater and lesser curvature. And on imaging, PET-CT showed a partial resolution of the primary lesion following chemotherapy. And this is the CT. Which shows the presence of the lesion extending into both the greater as well as the lesser curvature of the stomach from the OG junction now. And the CT of the chest was unremarkable. The diagnosis, the final diagnosis was carcinoma OG junction, severe type 3, post neoadjuvant chemotherapy status. Plan is to do staging laparoscopy followed by total D2 gastrectomy. Thank you, sir.
Welcome, Dr. Pradeep, sir, also.
Good afternoon, sir.
Good afternoon, sir.
யாரு கடைசி ஜாயின் பண்ணது?
Dr. Pradeep, sir.
Okay.
Good afternoon, Palanivelu.
Good afternoon.
How are you,
seeing
sir?
me?
Yeah, I'm
fine.
seeing you, sir.
Are you getting my video?
Yes, sir. Very good.
Okay, fine. Thank you very much for this AMASI Lens program today. I have my own friends as an expert panel here to comment on. I think I have no need for me to do to talk about. Only I'll be doing it. You all can interact. You can whatever way suggestions. I'm happy about it. So I will show you the port placement, and you can appreciate. And the trocar is already placed. And this is a camera trocar, supraumbilical.
We need a
This
PIP,
is
sir.
12 mm.
Yeah.
Yes. This is a 12 mm. And normally I will put it here if it is a gastrectomy. I don't know what will happen in the lower end of the esophagus. So I placed it here, and I may division of the esophagus is necessary. I can use the stapler here. Then is one more fine trocar anterior line for the gastric traction. So while we introduce this camera, you can appreciate inside. Now you can appreciate that. So getting inside view now.
Yes, sir.
Yes, sir.
Yeah. They can put it picture in picture. And hold this 2 3 4 steps. gas piece எடுத்துங்கம்மா. Hold this. Lock பண்ணிக்க. Okay. Hold this. Sister, curved கொடுமா. Now there is these are all developmental addition, and I did a diagnostic lab, and thinking that any peritoneal seedlings or not, I'm happy that it is resectable. Already we have seen, and you can say I went up to seen a great momentum, all visualized beforehand. So this is a resectable lesion. You can see nicely stomach is little more distended, and but no obstruction here, antrum, it is all free. Growth starts from here only by endoscopy, but the whole of the stomach involved. But endoscopic wise, the growth starts from OG junction. Then I don't know how much I'm going to get it free esophagus, then we'll decide. And some, in case necessary, must be prepared for IV Lewis. And if we don't get adequate length, that will be decided frozen biopsy of the lower end. And grasp. And now see, we have seen here and we have examined, this is a pancreas. We can appreciate the nodes along the common hepatic artery and the bifurcation here, cardiac lobe. There is a nodes here again. So this all will be removing it. And I lifted and see we can, it is free from the pancreas here. And I think it is a greater curvature in all. I may be removing the nodes at the hilum of the spleen also. We'll do total gastrectomy end block. We are planning. Lock. See, I'm just lifting the stomach. I'm planning to do a total end block. That means I will be removing the lesser sac as well. Great momentum and a lesser sac, including the peritoneal covering of the pancreas. Now I'll remove this retraction. I will put it here. Hold this. Okay. Harmonica ila poduma. I'm using harmonic scalpel for dissection.
Is there a nodule there, sir, in the ligament?
Short and pardon?
Is there a nodule there, sir?
Ligament.
Ligament teres.
Pardon?
Just where you are putting and retracting the there. Little more up, sir. Little more up. In that area. That's there.
Yeah,
that's a nodule.
Here it is a gallbladder.
No, nodule, sir. In the ligament. Mele, sir. Here,
So
yes,
the retractor what has been used.
That one.
Yeah, that one.
That one.
This is fat, no?
No, I'm just
It
asking.
looks like a nodule. Sir.
This one.
No, it is not nodule.
Right, sir. Right.
It's a fat, sir.
This is fat.
Thank you. No, fine.
Yeah.
This is fat, no?
Fine, sir. From here, it looked like a nodule for me separately.
No. Yeah, correct. What you meant. That is why we have to look at. Doubt is there, we have to take it. This is, I saw it is already fat.
Fine,
Now
sir.
you can see here, this is pylorus here. This is a duodenum. And this is additions. So what we'll do, I release this now itself. Camera come back.
Sir, according to the plan is you're going to dissect in the hilum of the splenic area and you're not removing the spleen, correct, sir?
Yeah, exactly. There is a CT scan showing a clear plane between the spleen.
Okay, sir.
And I hope so. But sometimes when we go, then will be known. After chemotherapy, we don't know. There may be nodes adherent to the greater curvature, may not be. Sometimes, we must be also keep in mind that splenectomy need or distal pancreas very rarely. Pancreas by CT will be known, but hilum of the spleen, chemotherapy nodes, we don't know. Sometimes it will be a problem. We have to keep in mind there. Okay, right.
So now positioning of the patient, do you have any advice for us, sir?
Position supine head up, I'm keeping it, and
any right side up or anything for this particular?
This side I'm going to raise it right side, and till because I'm going to dissect the start on the right side first.
Yes,
It's a sister table right side raise பண்ணுங்க.
So as you have taught us initially, the main principle is to use gravity wherever it is feasible so that the organs
that is the
get
greatest advantage of laparoscopy or robotic is the gravity.
gravity, sir.
You can see the colon going up to the hilum medulla.
Yes, yes. So your preferable instrument on your right hand is always a harmonic, sir?
Harmonic and alternatively I use ligature in between necessary. If it is obese people and the great omentum and these are all very bulky omentum is there, then I use ligature. But otherwise, harmonic is a commonly used instrument.
Yeah, in this patient, its BMI is 14, I thought, sir. That's what.
No, only see. Sets pidichukku, mani pidichukku. I am going between the gallbladder and the colon.
Okay, sir. After picture in picture,
yeah.
Picture in picture, sir.
Sister,
change பண்ணிட்டேன்.
Sir. Sir, you always prefer standing between the legs, sir?
Almost 100%. But today I thought of showing notes, clearance standing on the right side of the patient. And but this case looks very thin patient. There is no need for it. And otherwise, some surgeon prefer some alternatively. But between the leg is my usual position.
Okay, sir.
Come back.
As of now, your assistants are being used for retracting the liver, correct, sir?
Come back here. Now I'll start regular one. This is where step 1, step 2, like I always go between the, I am lifting the antrum of the stomach high up. Then I'm going dissecting between the antrum and the duodenum part 1 and dividing the gastrocolic omentum.
Okay.
I'll go into the right gastroploic vessel, then continuing it. I don't open the lesser sac, and I'll go taking the layer of this covering the pancreas going from this side. So the end block will remove the lesser sac also. Come. Gas piece kudukaliya.
Your group has a knack of giving a gauze roll also, no, sir? You have a separate technique of giving a gauze roll also. That will also be useful, sir. You should show us how they do their gauze rolls and.
Dr. Ayyappan, this is Dr. Parsad.
Yes,
we developed already the technology is there. It is called a teleslater. So usually the illustration, during a time of suppose you are presenting your videos or lecture in iPad, you can mark the structure, you can mark the presentation. That can be done during live surgery. This type of remote things, it's possible. Today I am going to do that. It is called teleslater. teleillustrator. And you can see, just I'm going to mark it's a transverse colon. Can you see?
Okay.
If not, okay, 1 minute. No, I'll change the thing so that
Partha, what is it called? You said I
writing
didn't.
in my iPad, it will be everyone can see that. So
Partha, what is it called? Tell you what?
teleslater, slater,
Okay.
teleslater. It is illustration, illustrator, and
Okay.
we are doing it in a remote place, so it is called teleslater. Yeah. Maybe after some time I'm going to show that thing. So whatever the code Chief Sir is taking, I can mark the structure, station, anything you can write. So it will be better for young surgeon education.
For doing so, what else is required apart from an app or something? Teleslater, I'm asking.
Yeah, that is actually I'm doing it on app only, but it should be done. Video should be in a NT format, NDI format.
What format?
Video into network format, like it's different
Network
format.
format.
It is suppose it has to go to one of the system and then come back without any delay, and so NDI format is better. Yeah. So now I'm going to mark a structure, and you can see this is the duodenum.
Yes.
So whatever I'm doing, it will be there. I can clear it.
Okay.
And so all the structures I can able to mark it.
Come back. Yeah.
So now this is the.
Partha, this is what we use in the robotic thing also.
Yeah, it is there in robotic. I came to say that.
Robotic thing is there.
Robotic, you can directly draw and show.
Yeah.
So trunk, gastrocolic trunk, what Chief is holding, it might be.
Now one is the colic branch, other one is the duodenal branch. And what we are starting to see is the pancreas there. So
that may be the middle colic origin, and
this is where the bleeding can happen when we do the right hemicolectomy laparoscopically.
Yes.
If the traction is more, then this one starts bleeding, and it becomes a nuisance. This fellow is a very fragile guy. Generally, he can start bleeding. So our left hand is what is more important. As Sir is holding, left hand becomes more important. It should know what it is retracting. Or else this fellow will avulse and it will cause bleeding.
Sir, I am Pikedas from Bhubaneswar.
Now this is the right gastroploic vein.
Yes. Partha, you're writing everything is in your computer, right?
Yeah, I'm doing it with my iPad.
iPad, okay.
I'm in the control room.
Okay.
So it is. I'm just connected with our network with my iPad.
Okay.
So it is coming in a NDI format.
Okay.
And then it is without delay. No, it is in and out in the same frequency. So whatever I wrote, it will be done. It will be seen in any.
As long as Partha is not going to control the Professor Palanivelu, that's fine.
Sir.
Sir, what are you talking?
Yeah, he said it control room. And that's why I was worried who is going to control. Who is he going to control?
So otherwise called AV room, sir. Some AV room, something, sir.
Yeah. That is.
So
now see, this is.
People, sir. I'm not controlling anyone, sir.
Used to control, is it?
Bipolar edema.
Is it that the hell is trunk which is standing out?
Yes.
Hey, Dr. Beju.
Hi, how are you? Looking younger and younger.
This particular area becomes very important because if the nodes are there, what Sarah is trying to do is clear off all the areas, and then he might be putting a clip in that area because the nodes can be there and the nodes need to be cleared from this area. The pyloric area, the nodes need to be cleared. That's what Sarah is trying to do there.
That is group 6.
Yeah.
Subpyloric nodes, group 6. And that vein is another nuisance vein actually.
Correct.
Particularly while we are mobilizing for esophagus, that is gastric conduit, you should be careful that it should not result in a tear of gastroctomy. Here, of course, we'll be ligating and cutting.
That's what I was also telling about the other end, no, sir. Right hemicolectomy, this can
harmonic
get avulsed also at times.
Partha, what is the system you people are showing? You have to show off, no? I'm talking about 4K, etc., etc.
Partha is not in the control room, sir.
I thought I will control him. Okay.
But he escaped, sir. Because you started asking him, are you controlling Palanivelu, sir? So he ran out.
Last piece.
Sir, Vijay Kumar, sir.
Hello. Now I am going between the pylorus and the pancreas. Huh?
Okay, sir.
I am taking all the top tissues in front of the pancreas.
Yes, sir.
That is the right gastroduodenal artery which is coming. Is it not?
Dr. Ayyappan, you called me.
Sir, do anytime have you started doing this proximal gastrectomy, sir?
Which one?
Proximal gastrectomies.
This one?
No, sir. Vijay Kumar, sir, I just asked.
Yeah.
Sir. Any proximal gastrectomies?
We were doing is the correct answer.
Yes, sir.
And now, as far as possible, my philosophy is simple. If you can do the anastomosis in the abdomen, I'm a happy fellow. If I cannot do it, I try to do it in the neck wherever it is possible. Only I am not able to do both of this, then only I will be going to the thorax.
When both these options are not there, you try and go to
the
Vijay.
Yes, sir.
Vijay Kumar.
Yes, sir. Yes, sir. Good afternoon.
This statement is 2011 when we are doing esophagus.
Yes,
you
sir.
mentioned this. Huh?
Yes, sir. Yes, sir.
Now, after that, I tried lot of techniques.
Yes, sir.
And I'll be showing next month. Yes, I will be clean.
No,
I will show a technique.
I have seen you doing, sir. I only said I am afraid.
Yeah. Bipolar.
In the setups where I was working, that is particularly low economic groups like Hidwai now in a teaching institution, if a leak occurs, it becomes rather difficult to salvage them. That's all. I said it's a personal bias. I'm not talking science here.
Harmonic. This right capillary artery here, vein we divided. I am taking the first one, the duodenum, from the pancreas. Clip. One more clip. I just clipping at the origin of the from the GDA. Just
Okay.
harmonic. இது பிடிக்குமா? ஓகே, அப்படி பிடிச்சு. You can appreciate the GDA here.
Yes, sir.
தூக்குமா? Today I wrongly made it that right hand as a 12 mm trocar, planning for the future stapling, but unfortunately that it is not good. 5 mm instrument is nice, and the stapler partial or subtotal I'll put it right side 12 mm because esophagus I'm making it here. If I put a reducer, that reducer comes in my instrument.
Okay. So you're finding it difficult for maneuvering, sir?
No, the instrument is 5 mm instrument, 12 mm trocar is not good to handle. 5 mm trocar, 5 mm instrument better. If you have sleeve, fine. Sleeve is disturbs me.
Disturb.
Okay, leave it down. Uduma, இது பிடிச்சு. Keep here. Keep like this. ஏய், இது கீழே கொண்டாமா, கீழே கொண்டா. அப்படி ரைட். bowel grasper. ரெடியூசரில் போட்டு கொடுங்க. ஹார்மோனிக் எடுத்துரு, ரெடியூசர் எடுத்து, ரெடியூசர் எடுத்து வேண்டாம்.
Sir, some of the question is there in at university.
Pardon?
Questions are there, sir, from the delegates.
Clip paduma?
It's a metal clip or hemolog clip, which is your preferred clip?
Hemolog or?
Metal clip.
I think most places I prefer titanium clip, generally what we using it. And venous clipping, any vein you want to clip, then use it hemolog. And for gastric, left gastric artery when doing a first clip, I will put it hemolog, then I will go for titanium clip.
Okay, sir.
And the gastrectomy, nothing specific, anything is okay, no, nothing is going to make it up.
Okay, sir.
And leave it.
Please, can you enumerate the standard steps of gastrectomy? That anyway you are there seeing all the steps. They are going to see.
A stapler. Pardon, Parsarani?
They want to know the steps of gastrectomy, sir. What are the steps?
They want to know the steps of gastrectomy, sir. Anyway, that is what you are showing.
Okay. What now you have seen, I cleared the nodes along the right gastrophilic vein and clear the node. I lift up the antrum and the pylorus from the pancreas. Hereafter, next one, I'm going to divide the duodenum. Before division, I think I will show the stripping of the posterior. Once divided, then we lose the control. I will do it this.
So for that question, what Sir did was first he explored the subpyloric area. He dissected off all the nodal tissue, alveolar tissue around the right gastric region there. The epiploic vessels were the one, the vein was the one which was ligated first. For that also he has used a metal. You can see that on the screen. Metal clip was used. And then the artery came into view. So he has dissected and taken off the artery also. And there also he has used the metal clips. When you are asking a question of what is that you prefer, generally surgeons, whatever they are used to in each of these steps, they'll try to use those tricks. And if your clip applicator is a good one, over the period of time you know how the applicator is, you will be able to use that particular type of applicator. Now he is stripping off from the pancreas. The fascia is being stripped off on the pancreas, and this is one thing, it's called the Morse procedure. That is what he is trying to do there. The bursa is being removed because it is believed that microscopically the disease can be there in this fascia which is covering the pancreas. That is the posterior wall of the gastric wall. So he is trying to remove off that fascia so that whatever the microscopic disease is there, that is also removed.
Once this portion is over, Ayappan, what I am going to do for the nodal clearance of the common hepatic artery and the celiac axis, then going towards the left. Hold this.
That is, once that particular area is removed and he gets that window, he'll be able to see all the common hepatic vessels comfortably. He's going to do the dissection there. See that fascia, how Toll's fascia is nicely coming out.
Sorry. I don't know whether the students are hearing you. It's called as Toll's fusion fascia. And also at this place, after the clearance, there are two ways of addressing this. Some of the surgeons at this point go to the common hepatic, clear it, and then staple the duodenum, and then start lifting the stomach in their hand, and then makes it easy for them to go to the common appendix. Whereas some other group of surgeons go down as he is now doing, lifting it up and go to the common hepatic with stomach attachments intact. That is duodenum and esophagus continuity will be maintained, but still they will go. Either of the two is fine, but the idea here is how comfortable you are to go to that place and able to see properly and take care of the nodal dissection effectively. That should be the way, but the modifications are always there. Cut and pull it up, cut the duodenal part and stuff, the whole thing gets lifted up, cephalate, so that the whole area will open up. But some of them are going like this over the pancreas, dissect without.
Stapler. Now I'll go for stapler, division of the duodenum, and white or blue is always question asked. Thin duodenum you can use white, and camera here, this side camera. Oh, and thick duodenum always choose blue. Leave it. You leave it here.
But do you need to do a bidsectomy on
Pardon?
cases, even if you are doing? Do you need to do a bidsectomy at all?
என்ன கேள்வி கேட்டாங்க கேளு?
No, bidsectomies. He is talking about bidsectomy now. Until bursa.
Yeah, I will do posterior stomach wall if it is involved, and I'll go for a birsectomy. If it is anterior wall and posteriorly not involved and early lesion, then there is no need for it. Now see pylorus here, I am 2 to 3 centimeters taken out, then going here the dissected, and now I am going to divide. அவன் கொடுக்கலையா ஸ்டெப்லர் வரலையா? You can appreciate here I divided just lateral to the GDA, and yeah, you can appreciate. And this program is sponsored by Merrill. I'm expecting his stapler to come, but it is not coming, so I'm using a regular one here. If it comes, I may be changing it here. Now see this upper border of the pancreas.
So actually, the way of removing this fascia, it actually helps us. It leads us to all the major vessels, as Dr. Vijay Kumar sir was telling. The celiac axis will be able to access that area very comfortably when you do this dissection, because that is a very important thing we need to understand. Because a lot of people will think straight away, let us go to the vessel. In fact, if you go posterior like this, you'll be able to access the vessels more comfortably. The celiac axis, all the 3 vessels can be seen very comfortably. That left gastric artery can be easily made out when you do this procedure. Sir, how many times do you face pancreatitis, sir? That is one of the problems which is generally described when you're doing these.
No, I never come across pancreatitis. Pancreatic leak after distal pancreas I had.
That is a different thing.
After birsectomy, no, I have not come across any case.
Yes.
No, but must be careful not to injure the parenchyma. That's why this approach gives you a very clear, plain identification between the peritoneum and this, and that may be one reason. That's why I'm showing today. Bipolar.
The literature-wise, post-gastrectomy pancreatitis is a known complication, although rare.
Yeah, it is known. Yeah,
and it is about 5% in the literature.
I think 10% probably is open or laparoscopy.
Sir, when we do this particular procedure, it's a known instant that the chances of pancreatitis is there, but because you are handling it very gently and you are not swept over that of the pancreas, maybe your incidences are very low.
Yeah,
maybe that's why you have not faced any of those cases, sir. Because we saw the movements what you were doing. You have never put your instrument, the right hand instrument, on the pancreas, because
never we put it. Yeah, that is probably maybe technical.
Technical
that
things. See here, another one thing is always remember about the pulsation, the superior border of the pancreas. You need to be careful about the vessels. So everything which is round is not a node. We need to be careful on that area. So remember, always in abdomen, the pulsation and the peristalsis are two key things which we need to keep in mind. That should be subconsciously running in our mind.
This is the right gastric artery I clipped here, huh?
Yes,
and
sir.
I think it looks not holding. Amma or clip kuduma.
And what is actually seen there is the common hepatic artery taking it to,
Yes, sir.
and he is holding the right gastric.
Come here, show here. Scissor, bipolar. Scissor kuduma from bipolar kuduma. பரிசேதன் கேட்டேன். Take it out. Clean. Bipolar.
So the two assistants, the one is holding the retracting the liver, correct, sir?
Yeah, one is on the liver. The other sister is helping the other side. Huh?
Okay, sir. Okay, sir.
You can see the common hepatic artery here.
That's what I told, that pulsation to be watched for. Yeah.
Harmonic.
So this is common hepatic artery, GDA. This is the hepatic artery proper.
This instrument will be retracting this side, and common hepatic artery neural plexus you are able to see there.
These are the amazing things about laparoscopy, sir. The visualization.
Yeah. But this case,
yes,
very
sir.
thin patient, 37 kg.
Yes, sir.
And, yeah, chemotherapy also given. That is all making the tissues more fragile. Yeah, Abhi. Here, when we go, this taking notes, and we should see the portal vein that may come in the. That one injury can happen. Identify the border of the vein here. Pudi mang put manadula.
Yeah, you saw that, sir. Yes, sir.
This is the vein, eh?
Yes, sir. Yes, sir.
Harmonic.
Some people, they try to use the suction here to do the whole thing, sir.
Yeah, can be done.
So whatever you're comfortable, but this is a very controlled movement. There they will have some amount of bleeding and other things will be there, sir.
Post chemotherapy, if the response is good, actually, we'll be having more desmoplastic reactions. Rather than, of course, bleeding and oozing will be more, but I'm talking about getting the pain is going to be a problem in post chemotherapy when the response is good. That many times we see in germ cell tumors, etc., where the response is good, going on the vessels and trying to get the plane is an issue because of the desmoplastic reaction. Here it is actually not having that much, I would say.
Yeah, it is not much. Some cases, that's why there must be 6 to 8 weeks gap is essential for that all subside. Otherwise, will be sometimes difficult.
Sir, Vijay Kumar sir, we attempted one testicular tumor to do an RPL and laparoscopy. We faced this problem a lot. Really, open itself it's going to be difficult, but we wanted to give it an attempt and see because we thought we have matured in endometrial cancer. We tried the same thing there. It was extreme possible. We needed to open with because we wanted to try it. So, as you're rightly saying, sir, too much of desmoplastic reaction, and it was very difficult to even identify anything. So,
Recently, we had a case.
yes, sir.
Intraperitoneal chemotherapy, systemic chemotherapy, and because there was peritoneal railings and the great omentum and mesentery small bowel and multiple diaphragmatic secondaries, all were there. But after the peritoneal chemotherapy nicely subsided,
Okay,
and we did the diagnostic lab again, did a biopsy. Most of them are negative only.
Okay,
Then finally went to total gastrectomy. That particular case, as what we all discussed, the desmoplastation was very extensive.
Okay, sir.
That we have to go distally, we take it out the spleen and pancreas, because scanning wise already the patient had infiltration.
Okay, sir.
Bipolar?
En bloc, you took off everything, sir.
Yeah, everything same.
This is what we were trying to say, sir. Actually, when you go by this approach, you will go to the celiac axis now. The next thing is you will be able to hit the celiac axis there. So the whole thing, all the nodal things will get cleared when we go in that plane. So that is a question which has been asked for you. How do you prevent the inferior or the superior epigastric injury in para-umbilical port placement? Any suggestions from you, sir?
Pardon, Ayyappan?
How do you prevent inferior or superior epigastric vessel injury in para-umbilical port placement? Sir,
I'm not coming on this. We are not any epigastric vessels closer to midline, and
Yes.
we are lateral ports are going little away from there. Inferior epigastric vessel injury in gastrectomy unlikely.
Correct.
Very close. Suppose you go camera port and this closer, yes, possibility is there. And
So all your ports are above the umbilicus. So here, maybe the person is asking in terms of if you are approaching any organ in the pelvic area. So how do you avoid? So general teaching is you try and visualize and get the thing. You'll be able to see when the camera is put inside, and you'll be able to see the vessels by the translumination technique, and then you identify that the vessel is there. And you avoid the vessels and then go.
Anyway, any one working trocars must be at least 5 to 6 centimeters gap.
Okay,
and midline we choose umbilicus or supraumbilical for camera. Then we go 5 to 6 meter laterally from there.
Yes,
inferior epigastric vessels always will be out of your plane.
Okay,
but there are surgeons using it lateral camera trocar. And that particular case, yes, the chances of this may be there.
Okay,
and even some fundoplication of doing it or achalasia, the people put a camera on the left side of the midline.
Okay, sir.
That type of possibility is there. But otherwise, no, I always choose midline.
Okay, sir.
And, this is a left gastric vein here coming down. Clip on kuduma. If you use a ligature, these are all not necessary to be clipped. Harmonic.
Dr. Partha?
Parsarvi? Bipolar? Up camera. Sister bipolar. Now again, you can see the pulsation of this celiac axis that side.
Yes, sir.
And some instrument, if it pressing here, it is better.
Yes,
But
sir.
this stomach is sister holding it. Put it here, ma. Yeah. Okay. Now we can find out the cleavage.
Yes, sir.
Harmonic. Bipolar. I am going towards the splenic artery now. Here, before going to left gastric artery,
Yes, sir.
and I should take it up here, this corner.
That step, what you're asking, is a very important step, sir. The
Yeah.
traction and counter traction on the pancreatic body.
Yeah.
What we do is, because we are scared about this pancreatitis, we put a gauze piece there and then we retract, sir. So that pressure also, that's just to keep ourselves more safe. Partha, are you there, Partha?
Parsarvi? Come, gas please.
Partha is not here.
Okay. No. Just
Ayyappan, you tell me, I'll tell Venkadeshalam will do it.
Statistic question, sir. How often have you seen an accessory left hepatic artery, a branch of left gastric, being dominant supply one, sir? Yeah, there is a question in the question box.
It is 2% or lesser than that.
When the statistics now, I thought Partha will be able to take it more comfortably.
No, விட்டுட்டு பண்ணிட்டு.
இப்பதான் சார் உங்க நேச்சர் வந்துருச்சு சார்.
You got it, very nice.
இப்பதான் நீங்க அந்த ரொட்டீன் சார் பழனிவேல் சார் வெளியில வந்தாரு சார்.
ஒரிஜினல் வந்தா தான் கரெக்ட்டா இருக்கும்.
அது ரொம்ப வருஷமாச்சு சார் இந்த வார்த்தைக்கு, இப்பதான் கரெக்ட்டா இருக்கு சார். அப்படி நீங்களே சார், அதான் கரெக்ட்.
அப்பதான் அட்ரினலோ ஸ்டீராய்டு எல்லாம் வரும்.
அந்த உச்சு கொட்டுறது many a time அது நிறைய வரும். All those things have started coming now, sir. Good, sir. லைவ் ஷோக்கே இல்லாம இதாயிரும் சார்.
No,
habit seldom die, Ayyappan.
இல்ல இங்க காட்டு. gas piece down. வேற gas piece கொடுங்கம்மா. Suck.
Will we give a left up tilt at this point of
now
time?
we better have to do it. கொஞ்சம் ரைஸ் பண்ணுங்கம்மா. If you don't tilt before, then splenic hilum is the most important place to have to go. Amma, harmonic kudu, bipolar kudu. And the fresh gas piece கொடுங்க. Gas piece. I'll keep the gas piece. I'll take fresh one. Now I'll go for the left gastric artery. தூக்குமாரி பிடிமா vertical பிடி. Correct.
This is an important trick which Sir has done now. It is a very simple one, but it's a very important lesson. See, it continuously kept on bleeding. It's a nonsense ooze. He just kept the gas piece. He has gone to another step now. So after some time, when he comes back there, there'll be no ooze. That is the idea of his not keeping on buzzing that area.
This is left side of the celiac axis.
Yes, sir. So another point is, though the celiac axis, the name signifies the celiac thing, the structure, the size of the celiac thing is very small. It's in fact in millimeters, because all the three structures, they take origin from there. So everything will be adjacent to each other. Our routine practice initially used to be, before we take off the left gastric artery, we usually go and palpate the hepatic, whether the pulsation is okay in the hilum, and see for the pulsation in that area, check for the splenic artery, whether it is all okay. And then we used to, like it, that is in the initial stages. And now also we try to do the same thing, before we go ahead and do any clipping in that area, we see for the hepatic, whether the pulsation is okay, and also the splenic fellow, whether they're all okay.
This is the one, if you can do it on standing on the right side,
okay,
maybe
sir.
better choice. Japanese, many of them do like this. We can work out the circumferential dissection of the left gastric artery.
Okay, sir.
Hemolog. Suction கொடுத்து hemolog. Fresh gas எடுத்துதுமா. Suction.
For the benefit of the postgraduates, you can show once more splenic, hepatic before clipping the left piece.
Splenic now?
No, hepatic, sir. That is
hepatic, no, sir?
That is hepatic.
Suction.
Hepatic, right?
So now you can see, this is common hepatic artery, right hepatic artery, GDA.
Yes,
this is divided into the duodenum. Now you can see the splenic artery here.
Okay,
and that is a left gastric artery.
Fantastic, sir.
And if you suspect, this clearance can be done, but generally not necessary, because it is only fibrous tissue. Now, for left gastric artery, I will put in one hemolog clip first.
Okay, sir.
And because some juniors postgraduate will be seeing it, they can.
Okay, sir.
Regular clip kuduma, titanium.
I remember, sir, in 2006 or something, when you demonstrated, hooked the common hepatic artery, and then you started dissecting all around, sir.
Another clip, large clip.
At the the Cancer Institute, you came and demonstrated there, sir.
I was the moderator that time also, sir.
Yes, Vijaykumar?
I said I was the moderator at that time, I said. And I remember very well the nasogastric tube got coiled.
Correct.
And it was looking like, then I said, pull the gastric nasogastric tube. It got relieved. So everybody thought it was a tumor.
Yes, sir.
Then I said, no, it's not coiled nasogastric tube.
That is the problem with you, sir. You remember everything, and then you will.
Harmony.
I wanted to use some other word, but I am not able to use it.
That's fine.
That day, I think it was total gastrectomy. I did it, and there.
Correct, sir.
And then I went for transite esophageectomy same day.
Correct, sir.
அது விட்டுருமா? கேமரா கிளீன்.
அப்ப எல்லாம் வெறியோட பண்ணுவீங்க சார். இப்பதான்
ஏன் gas piece, fresh gas piece. Pardon, what do you say?
இல்ல சார், அப்ப பயங்கர வெறியோட போகும் கை. இப்ப ரொம்ப காஷியஸா போறீங்க. தட் இஸ் எக்ஸ்பீரியன்ஸ். தரன்னு போகும் சார்.
Bipolar.
விஜயகுமார் சாருக்கு ஏதோ சொல்லணும்னு தோணுது, சிரிக்கிறாரு, சொல்ல மாட்டேங்கிறாரு. இதான் வாய் விட்டு மாட்டுறது சார். I know I'm caught now, but anyway, I'm going to get caught. Tell me sir.
Nothing. As Professor Palanivelu is growing older, I am also growing old. We cool down before responding. Okay. We don't react. And the place where he is now dissecting, if you slip it down a little more, it will actually go to para-aortic area.
Yeah.
So many people are now talking about D2 plus in that area. And any comment, Ayyappan, about the D2 plus?
That now the concept is when there are obvious nodes are there, we try and do that, sir. Or else we are not doing it, sir.
Correct. But the D2 plus is a point. What I am trying to say is now you need not do a formal D3 as described earlier. When there is a node, you can slip to that area and remove it after doing D2. And not necessarily it should be a classical D3 just because one group is more than D2 what you are dissecting. And particularly the PAD, that is the para-aortic lymph node dissection. After D2, now they are writing D2 plus PAD rather than a formal D3. The reason they are talking about is that at this level where he is actually dissecting from celiac, the chances of it going towards aorta, that is para-aortic region, is much more than going to the other group. So you need not formally do a D3. That is the point they are talking about. Because he is dissecting there, I thought I will inform the PGs about the concepts, how they are changing.
Sir, you can show them the portal vein, sir, now, before you do this. You can show them the portal vein, which is obviously nicely seen there, so that anatomically it will be good. Yes,
IVC.
Here.
Yes, sir. And the IVC is also seen.
Yeah, IVC also here. Then.
The whole thing is, yeah.
Reducer bowel grasp எடுத்துங்கம்மா. ரெடியா? Reducer. We have to label these nodes where exactly we are taking it, and then we have to do histology later on, then to properly stage.
For the benefit of the postgraduates and trainees, the moment you remove these nodes, it should immediately go to the 10% buffered formalin at the earliest.
Yes.
The reason here is simple. The cold ischemic time can change if not the histopathology, autolysis can occur. Here, of course, we may not be doing IHC and all that. Suppose if you are doing IHC, the IHC markers in other areas, I'm talking here, IHC doesn't come into the picture. So it should, by habit, it should go immediately in no point of time, you should not keep it out beyond 1 hour.
Hey.
The reason why Sir is trying to tell this is whole of oncology is nowadays changing into two things, that is imaging, and your diagnostic is mainly by that of molecular oncology level. So it is not only the morphology that matters nowadays, it's in the molecular level is what we are talking about, that most of the treatments are also now going towards that of molecular oncology. So if the ischemic time becomes more, the loss is going to be, or the degeneration of the proteins also happens, and the genes also happens. So that's why Sir is saying, as soon as it is taken off from the feeding blood vessels, it needs to go into the formalin. The earliest it goes in, the information on the genetic component will be preserved. The proteins and the genetic component will be preserved for molecular oncology.
Now you can appreciate the artery this side.
Yes, sir.
This is artery.
Yes, sir.
Little fibrosis is there. Desmoplastic. It is not just like. And posterior gastric artery, it comes better to put clip, or we can cut with the ligature, but should not cut with including the fatty tissues. Then the vessel will not get sealed well. Close up here.
White வரலைங்க சார். பர்பிள் இருக்கு, அது ப்ளூக்கு ஈக்குவல் அப்படின்னு.
ஓகே, சரி, எடுத்து வை பார்க்கலாம் எப்படி இருக்குன்னு பார்க்கலாம். If you go more posterior, adrenal will come, this level.
Yes.
So we can stop this, then we can come the other side later. Okay. Suction, Kuduma. You keep like this. Suction, irrigation. Gas piece.
For the benefit of the postgraduate students, the dissection what he did was along the splenic artery over the body of the pancreas and towards the tail. And when it comes to D2, whether to remove the hilar nodes that Dr. Ayyappan in the beginning only discussed, for a proximal third, coming to the greater curvature, that is 4A area, that is short gastric area, if there is disease, then the hilar node removal is considered mandatory. Whereas otherwise, we will only take care of the celiac, the gastric, common hepatic, and the proximal part of the splenic artery. Those groups of nodes in the named vessels are removed apart from perigastric nodes. That makes it D2.
The latest Japanese has not included the number 10 lymph node. 42 dissection.
Number 10 is in the hilum, no, sir?
Pardon?
Or proximal third.
Yeah, it's not included in the latest Japanese.
Yes, sir. Nowadays they are not included hilar node in D2.
No, that's what exactly I'm telling. Yes, hilar node removal, it was considered as mandatory earlier. We are not doing it. And when will you do is also the question we are talking about proximal third and which is coming towards the greater curve.
Yes, sir.
Yeah. What we are now seeing is actually the spleen.
This is spleen.
And he is working down the esophagus.
Okay, down.
I think the right sleeve is out, is it?
The so-called abdominal part of the esophagus.
I think he's holding the nerves now, sir.
Yeah.
Vagus
I'm
now.
taking the posterior vagus now.
Posterior vagus, yeah. The crust of the diaphragm is nice. Crust of the diaphragm is made out nicely there.
Partha, super Partha. Nice app. Very nice app.
Thank you.
The cursor you are using is a pen or what?
Yeah, I'm using with my pencil in iPad.
iPad pencil.
Yeah.
Left side, right side.
Adapuna, you can show it in picture in style.
No, sir, it is not. I'm not inside the OT.
It's in the control room.
It's still in the control room, you know.
Yeah, okay.
There are
Even I can show the surgery is going on in other OT also, sir.
Okay.
So that is the advantage of this technology. So all the OT is through fiber is connected to my room, this AV room. Also, you can see other OT surgeries. There is no need to take a wire from that particular surgery, particular OT.
Partha is controlling everything. The CEO.
No. No, sir. It's a for education is. I think it's good. Even though we can tell this is the structure, but the surgeon need not to know. They are not showing all the time. So if you mark it, it will be better, sir. Yeah.
This is a splenic flexure.
Yes, sir.
I am taking these layers, so I will go in between the two layers to clear the hilar nodes.
Okay.
கீழே பிடிக்கணும் இப்படி இதர் பிடிச்சிக்க. Yes.
Sir, do you change the position of the patient, sir?
No, I have not changed. Left side I made a little more.
Okay. Left side is up, sir?
I tilted the table a little more. Gastrectomy, generally I don't change my position.
Okay, sir.
All of them, staff, assistant surgeon, all remain the same person.
But table tilting alone will happen.
Yeah.
Sir, what is your concept of the omental removal, sir? Retromentum, I'm talking.
I will remove, no?
No, something is changing. That's why I asked.
No, there is views to different, but our Indian setup, we have to remove because most of the cancers comes to us is advanced stage. And what the Koreans and Japanese call advanced is different, early different, no? And so that's why I'll remove it. And of course, we're doing it. I'll be showing it, but initially I used to start great momentum first.
Yeah.
Now I'm changing it, great momentum last.
I continue to remove even today. I want to know from other moderators. Sir, Senator, sir, what you do and what I can do?
You do total omentectomy with gastrectomy, and we do birsectomy. Though I asked the question, we do birsectomy as well.
So we do.
Ayyappan, what is your view? Or do they take it great momentum always or not?
Yes, sir. Always, sir.
Sir, suppose in early lesions, sir, like a T2 lesion, is it necessary to go remove entire momentum?
Sir, as of
I wish I have once. That is the problem. In our country, as Professor Palanivelu is talking, CA stomach ultimately, by definition of EGC of early gastric cancer of our Japanese definition, I would have probably hardly seen in my the last 39 years. So the problem here is we always go as a habit, treat it as locally advanced, and do omentectomy and vasectomy, etc. Even though some of the papers are now trying to, as Dr. Sanadiappan sir now spoke about vasectomy, whether you remove, etc. They are all coming in. But as a matter of fact, we are routinely doing it because I don't find any reason why we should not do in an advanced disease. On the other hand, I think it is probably an habit which we don't want to change because nothing has happened by removing, adding something more. Somebody may consider it over treatment, but by adding that, we are not considered anything extra in the form of a complication occurring.
There's no morbidity, sir.
Remove the toes fascia and remove the...
In fact, it eases out. It eases out our whole thing. So it's better that we remove it also, sir.
Okay,
the procedure also becomes more comfortable, and anatomically will also be more comfortable in the retrogastric area.
They go to the stomach. So Ayyappan, did you appreciate that stomach wall?
Yes, sir.
It is thick walled. I'm not able to catch with the instrument.
Yes, sir.
It is a tumor there.
It must be the diseased part, sir.
Yes.
Because you are going towards the proximal third at this point. So obviously, probably you are handling the diseased area, at least which was there before NACT.
ஒரு கிளிப் எடுமா.
It is short gastric. Is it not short gastric? Yeah, it is. No, it is coming on the moment. Right is left gastric.
Maybe left gastric, like
left gastric, yeah.
Left gastric, correct.
That is the just below it is the
splenic
vein.
Clip.
The one which has started is from the splenic vein, sir.
Yeah.
Because the pancreas is slightly tilted, we tend to see that splenic vein also.
Yeah. So you can leave it, then you appreciate. Right?
Usually the one vessel goes to the tail of pancreas from the splenic vein, and one branch go to the tail of pancreas, another is going to the mesocolon, transverse mesocolon.
This is the arch, no? Epiploic arch. One side we did it there near the duodenum. Now here it is. You are doing on the left side.
Yes.
This is short gastric.
Yes. Hey, lift. Lift. Knee utruma. Keep like this. Huh? That fundus and the greater. Hey, in your artery, got a clip.
Whole
One more
body
clip.
sir. This is the place it started bleeding. Yes, sir. Yeah. Now it's better.
Not the branches or splenic arch.
This is one of the splenic branch to the tail. Huh?
Yeah, polar branch.
Hey.
No, sir. Some more up it has to be applied. I think clip from the left
Other
hand
side.
is better, sir.
Other side, correct.
Suction.
Okay.
Suck. Suck. இல்லம்மா சக்ஷன் ஒர்க் பண்ணல பாரு. ஓகே, நோ கேஸ் அட் ஆல். ஓகே, எப்படி பிடிச்சி லிகேஷ்வர் இங்கே வச்சுக்க இப்படி. Many times that upper pole of the spleen will be ischemic when we are taking out the posterior gastric branch, but that will possibly it will gain no problem. Irrigation suction, keep like this.
While operating in that area, many times the splenic capsule can tear.
Yeah.
Particularly when it is very close to the stomach, when you tend to go closer to the spleen, then the chances of splenic.
Yeah. But many cases by injuring the vessels have done a splenectomy, and few cases that even no involvement, but
Correct.
when you're working on possibility is there, we have done that.
So that what we do is we take that as a last decision. We also face that problem. We'll have the tear. So we try to keep the gauze place, surges back, all those things. Nothing will help. So ultimately, we'll want to justify ourselves that it is necessary because it's bleeding.
Gas space. Whenever you leave it, catch that.
Now, the trick what we use when we are opening open gastrectomy is what we used to do. We keep 2-3 packs behind the spleen, sir, so that bring it to the midline, so that traction will not happen on the short gastrics and the tear on the splenic. The capsule tear, bipolar is one thing, and high level of unipolar can also sometimes it has stopped.
No, as Professor Palanivelu pointed out,
yes, sir,
quite a few times when we are doing this, the splenic capsule tear may result in a unnecessary or unwarranted splenectomy, but we may not be able to stop many times, so it will warrant ultimately splenectomy, which is much better, easier to do rather than avoiding that and waiting and watching. But apart from doing splenectomy, anything else can be done to prevent splenectomy, taking care of the capsule. Any tricks are there? Anybody?
Sir, one is when we are doing this laparoscopy, we try to bring it to the midline so the traction may not be there much on
No. I said differently. Now the capsule tear has already occurred. Maybe a small tear.
Okay, sir.
So at that time, without doing a splenectomy, what are the other things can do to handle that sort of tear is what I asked.
Sir, no. Anyway,
prevention is different. I'm not talking.
No, yes, sir. What we do is the mindset is there that we might land up with a splenectomy. So try all things, whatever you can do with the bipolar and monopolar. That is what we try to do, sir.
Sir,
We try
actually,
to burn
the
it.
splenic.
We try to keep some surgery cell there, and then over that we use the bipolar. We have been fortunate enough in some cases the bleeding stops, sir.
Head down பண்ணுமா patient flat
Dr.
பண்ணிக்கங்க.
Partha, you said
Sir,
something.
yes, sir. Yeah, if it is a splenic vein injury, then no other option, sir. Otherwise, depends on this. We can go for a surface means APC is enough, and if it is a big tear, then we can suture the spleen, sir. And we can keep all these Esophageal and snow.
Esophageal overturned, then suture.
No, Esophageal, no, snow, sir. Snow, Ethicon snow is there. And then it is like a partial splenectomy we are doing. We can suture the spleen if it is a linear, like a cut is there. That is the option, sir. APC and bipolar, it is all this for only for a surface use, sir. It is not for a deep from the parenchyma of the spleen. And I think suturing is the best option, sir.
Thank you.
Yes, sir.
Capsule tear alone, no need for a splenectomy. Any vessel branching, the ischemic of the spleen itself, then only splenectomy. And capsule tear, most of them as per Sariputine, we manage it.
I think Chief Sir is trying taking the anterior leaf of transverse mesocolon. I think for a total bursectomy is planning.
We
Yes, sir?
usually do this step from medial to lateral.
See, that is the capsule, sir. The anterior layer of transverse mesocolon, and then capsule of pancreas. Then it's become a total bursectomy. Question, sir. Any question from University?
Roshan, you are only watching or with eyes open sleeping?
No, sir, I'm actually participating.
Hey.
Just watching.
He is controlling the panelists.
கொடுமா இது விடு. ரைட் சைடு ரைஸ் பண்ணுங்க.
Will you take the anterior leaf of mesopolyphasia?
Pardon?
Will you take the anterior leaf of mesopolyphasia?
என்ன கேட்ட? Yes, yes, I always take it. Because I've done already the pancreas side. When I do great momentum, see, you can see here, and this layer can be peeled at this stage.
Okay.
Only thing must be careful not to injure the colon vessels. See this side all done, pancreas, lift up, then we will be seeing the plane, then we can. If I do great momentum initially like what we do before, this portion becomes a difficult.
The thing is, you do a omentectomy first itself, it becomes more bulky. So retrogastric section becomes very
Correct. That is what I was thinking.
Yeah,
That
initially,
momentum will be such a bulky one.
Yeah.
Retracting the stomach will be retracting momentum also. If you do
Yeah,
that in the
yeah.
beginning.
Yes.
Now the momentum was lying in some place, and we were only concentrating the stomach part of it, and adding it at the end looks more elegant in the sense retraction, etc., was not that necessary.
Yeah.
The bulk would be there. I fully agree with what Dr. Roshan is talking about.
And when I showed this technique in 2017 at Madrid, and the Hong Kong surgeons all were there, and they finally they agreed this looks different that coming from that side and taking up. That is. There is a window. At the last, we'll close it.
Yeah, the DJ flexure is being seen there, right?
Engineering to avoiding it, that also is very important. And yes, something more. If a growth is involving the mesocolon, we'll take it out the mesocolon, and we can the rent can be closed later.
you are close to the stomach now.
இது முடிச்சிட்டேன். இங்க பாரு இது பிடிச்சிங்க அப்படியே. You hold this one, huh? Yeah.
Yeah, this is one place where you can lose the plane and then go into the and into the vessel. Yeah, need to be very careful.
Roshan.
Yes, sir.
You know, in the lighter sense, you can lose your plane in many areas. This is one such plane.
Correct.
I hope you understood what I said.
Yeah, I understood, sir. Cannot be elaborated more.
Okay.
One small twig is there. That's it.
Bowel forceps.
Yeah.
You hold it here now. Gas piece. Vijay Kumar, I'm planning to do a pouch. How many of you are still doing pouch, or still there is a controversy whether some surgeon say no benefit and this irrigation kuduma?
Here, formal pouch I don't do, sir. But the anastomosis most of the time is with the J, sir. The loop to it will become end to side. That is, the jejunal side will be the side, and the end will be there if you are using it. And many times here in the anastomosis, I use linear stapler. That is, I don't use circular here, if at all, is a stapler, and I will be using more of linear ones, so that we get a better
the advantage of linear is we can make it a wider,
correct,
a wider stoma, narrowing. It is tension free and the leak also not there. Future restriction also no. Harmonic kudunga.
Correct. That's what I prefer to
do. Stapler kudunga avanga load panni. But if it goes to the mediastinum, what I'll do inside anastomosis, then I'll do circular Orville. Okay. Stapler. Now this is a growth endoscopically here, and this is endoscopy normal.
How much clearance macroscopically you are giving, sir?
Pardon?
From the tumor.
I'm going to take it 5 centimeters.
Tumor, how many centimeters approximately?
I'm 5 centimeters. I'm planning it. Huh? 5 centimeters is okay. No, adenocarcinoma. That is fine.
Yes,
it's a civet type 3.
Type 3 it is.
Yeah, type 3, I think 5 centimeters.
Huh? Pardon?
Type 3, it's civet type 3, is it not?
Yes. Yeah, it is type 3. Adenocarcinoma type 3. Yeah, Dvoji junction.
It's 5 centimeters,
This is Merrill.
Why purple, sir?
Huh?
Why purple?
Pardon?
Why is purple country?
According to them, purple is equivalent to blue.
Oh, is it?
Is it? What is a pin size?
And
yeah, it is a medium thickness. That's what say. I checked it. Now we have been used blue, white, and no.
Sir, NG tube has been withdrawn.
Have they removed the NG tube? Both of us are telling the same.
The sisters already checked it. They pulled out. நீ வெளியில எடுத்துடலாமா? ட்ரொக்கர் இல்லைம்மா, அங்கே ட்ரொக்கர் இல்லை. ஓகே, இதுக்கு மேலே ஓப்பன் ஆகாதா? ஓகே, ஐ எம் டூயிங் ஃபர்ஸ்ட் டைம் நோ திஸ்.
My sir saying it's first time means this particular instrument from this particular company.
Yeah. இது பிடிங்க.
Yeah, that's why I asked. We generally use blue.
Yeah.
That's why I asked about this purple.
You have to see the other side.
Yeah.
And we generally staple from the left side.
Open.
Avoid any.
Okay, இதே மாதிரி தானே. I am asking sisters, they are telling me how to do this. பிடிச்சிக்குது, all these. This is like a comedian, Medtronic. I usually take a stay sutures on either side, but today I have not taken because I am going to put a bougie inside. At that time, I will be taking it this. And this linear stapler, this case, it is going to be, I think, difficult. We'll see. Otherwise, I have to make it widening than doing it. Harmonic. Crowd eduma the clipper slip வச்சிருக்கீங்களா? Bowl forceps.
For the trainees who are seeing total gastrectomy first time, now the clearance is already over. Gastrectomy part is over. What we are going to do is only a reconstruction part of it using the jejunum. And currently, what you are to seeing is called as the gastric tumor bed area. What is pulsating is the hepatic artery, and then the clipped one is the left gastric. There is cutting the crust of the diaphragm. Oh.
You should not too much, and pericardium will come.
You will enter into pericardium, sir.
Yes.
Yeah.
And my boys have shown me how to enter also.
Come back. முதல்ல பூஜை கொண்டாமா.
Here you should be careful about not opening the pleura. By any chance, you should only identify. And if necessary, you can put a tube. But not opening the pleura is better.
வருதம்மா? சர்க்குலர் எடுத்து வச்சுங்க. அதில் ஆர்வில் வாங்கிக்கங்க. 25. வருதா? சரி, இல்லைன்னா விட்டுரு, பரவாயில்ல. ஆர்வில் போட்டுருங்க. ஆர்வில்னா பூஜை போட வேண்டாம். ஆர்வில் தான் போடுவோம். லீனியர்னா தான் வேணும். கொஞ்சம் ஹார்மோனிக்கு பைப்பலர் கூட.
Sir, is that the vagus that you're holding on to?
Yeah, I'm holding vagus now, which I divided earlier. This guides me not go into the right pleural. Okay. இது விடுமா? ஆர்வில் போட்டுமா? அப்படியே போட்டுருமா? அடுத்து இல்லை, அது போட்டு இது வெளில எடுத்துக்கலாம். அப்புறம் மூடி இது பண்ணிக்கலாம். ஸ்மால் பவுல்லாம் பண்ணி வச்சு தான் போகிறோம். எடுத்துட்டு விட்டுரு. ஆர்வில் பீஜி வேண்டாம், ஆர்வில் போட்டுரு. Okay, now meanwhile I'll prepare the jejunum.
Jejunum,
yeah. Come back down. Head down பண்ணிருக்கணும். கொஞ்சம் பண்ணுங்கம்மா. ட்ரொக்கரில் இது விட்டுரு. அப்படி வச்சுக்க. Okay, now you can see here. Hey, இப்படி காமிச்சேன். DJ flexure you can hear, and here you can see IMB. And this model, we don't want to open there. And I'll take the loop. It should go without any tension there. Leave the colon. Now leave the colon. எடுத்துருப்பா. நம்ம ஒரு அம்பிளிக்கல் டேப் எடுத்துக்கமா 15 சென்டிமீட்டர் கூட. Good. We have to take the entire small bowel, there should not be rotation in the mesentery. Then loop will lie down free better.
Yes.
Yeah, think at it.
So at this moment will be the position of the patient we left up.
Yeah. Left up, and we have identified it.
Yeah.
I'm going to take it at 30 centimeters.
Okay.
And for roux and Y loop.
Yeah.
And that different loop I will make it the pouch
Okay.
after stapling.
Yes.
Down here, get cut. Okay, harmonic kuduma. போட்டிங்களா பிடிச்சிக்க. புடிமா நல்லா புடி. ஒயிட் போடுமா கேட்ரின் நம்மளுக்கு கொடுது இதுலேயும் கொடு. எத்திக்கான கொடு. அம்பளிக்கல் டேப் எது கொடுங்க. நாலு அஞ்சு லோட் பண்ணி வச்சுங்கம்மா. ரொக்காரி இல்லை. ஓகே. இதை பிடிச்சிக்குமா இப்படி இப்படி. இன்னொரு பவுல் ஃபார் சர்ஸ். You hold this. Okay. எவ்வளவு எத்தனை சென்டிமீட்டருமா? 15 கொடுன்னு சொன்னேன். 15 சொல்லி சொல்றேன் பாரு. அப்புறம் நான் கட் பண்ணிட்டு இருக்கேன். I am taking a 15 centimeter tape and assessing that loop 15 centimeter.
This is for pouch.
Yeah. Pouch length now.
Yeah. It's not for the afferent limb. It's for pouch.
Pardon?
It is not for upper limb. It's for pouch.
No. It is a pouch. Then only we are making it here. Afferent loop already made divided. It is there. I'm taking the efferent loop side and measuring it. Okay. Go up. Okay. Leave it. அது பிடிச்சிங்க. Don't hold this. நீ கீழே பிடிமா. Up camera. Okay. Harmonic. Hold this. Stapler. இல்லை அது கூட வச்சுங்க. எப்படி டிவைட் பண்ணி தான் ஆகணும். கொண்டா லீனியர் கட் பண்ணி தான் ஆகணும். கொண்டா லீனியர் கூட. ஹார்மோன் இது பிடிங்க. அப்படியே பிடிச்சிக்க. ஹார்மோனிக் பிடிமனாலும் விட்டு வந்துக்கிட்டு ஸ்லிப் ஆகுது பாருங்க. Suction. கீழே அப்படியே. ஓகே விட்டு அது விட்ரு அப்படியே பார்த்து. லிவர் அட்ராக்ட். ஆர்வில் போடுமா.
Is this Merrill company is having Orville?
Pardon?
Is this Merrill company is having Orville as well?
என்னென்ன
Merrill company is having Orville as well?
No, I'm using circular stapler. No, this is inside going, and linear stapler we use may not have a. Can we do it?
No, sir. We may have trouble, sir. If you use linear, you may have trouble in negotiating this.
Yeah.
Linear. It is going back. The
harmonic. Push. Push. 2-3 forces சொல்லுங்க. Fumes எடுத்து கொடுங்க. Fumes out பண்ணுங்க. Deflate பண்ணுங்க. எண்டோட்ரிக்கல் இது இதுல இரு நீ ஒன்றும் பண்ணாது. இனி அது பிடி இல்லை நிற்குமா கேஸு இந்த ட்ரோக்கர் தானே. Camera closer. Here you put it inside a track like this. தள்ளு உள்ள போயிடுச்சா? எவ்வளோ இருக்கு? வந்துடுச்சு. ஓகே. என்னம்மா சிசர் இழுக்காத போ. இது கூட ஃபர்ஸ்ட் கூட அது நீ த்ரெட்டை வச்சுக்க அப்படியே போதும். சேஃப்டிக்கு தானே அது. ஓகே. ஓகே ரைட். Light outside, please. I'm widening that 12 mm trocar. I removed it. I'm going to make it a little wider so that circular stapler will go in. And we put a plastic cover for the end of the head to go in this outside. I'm a katri kuda.
Can we have the external view as well?
Case close பண்ணிக்கங்க. Alice kuda. What you ask?
External views. They are showing it now.
தூக்கு மாதிரி பிடிமா உள்ள பிடி அப்படின்னா கரெக்ட். நல்ல ஆலிஸ் நல்லா ஆலிஸ் கொடுங்க. கொண்டா கொண்டாது கொடுங்கம்மா. ஆனுவல் கொடு. இந்த ஸ்டேப்லர் கொடு. பிடிச்சிக்க. இல்லை எப்படி மடக்கிடுமா? சரி வேற டியூப் ஆகும். யார் கட் பண்ணுது அது? இது ரொம்ப பெருசு. ஏன் அந்த கேமரா கவர் இன்னொன்று எடுத்து கட் பண்ணிக்கிறது என்ன இல்லையா? We should have a narrow cover. And not this is a regular Euro bag. பிடிமா ஹெட்டை பிடிச்சிக்குமாங்க. எனக்குள்ள கொடு காட்டுறி கொடு. என்ன இது வேறு எதாவது ஒன்று ரெடி பண்ணி கேட்டேன். கேமரா உள்ள போ, கேமரா உள்ள போ, கேஸ் ஆன் பண்ணுங்க. இங்கே காட்டு, இங்கே. This tube open should not pulled out. While cutting it, the specimen will come. That don't this. Emma, Alice கூட எடுத்துறதே. பவுல் forceps என்ன கூட. கீழே கட்டு. I have to see whether rotation is there or not. That is. கேஸ் மாட்டுங்க மாட்டுங்க. ஃப்ளோ ரேட்டு ஃபுல்லாக வச்சுங்க. ஓகே. இங்கே 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 போ. மேலே கேமரா. ஓகே. நான் எங்கம்மா கேஸ் போட்டு அந்த மாதிரி க்ளீன் பண்ணி வேறு மாற்றுங்க கேமரா. அதில் போடுங்கம்மா. ஹோல் திஸ் ஒன். கேமரா க்ளீன். Okay. Leave that. இது விட்டு கொடுமா. So I'm going to insert into the, put all this. I think I used a circular stapler long time back. விட்டு கொடுமா.
We are seriously using only endo-GI.
Yeah, this after many years I'm doing it. இதை பிடிச்சிக்குமா. அப்படியே பிடிச்சிக்குமா. You also keep like this. Hold this. Up camera. Anka poi tip kada. Show up.
Because you are going to do a pouch, is it mandatory that you have to have a length of 15 centimeter here?
Pardon?
Because you are going to do a pouch, is it mandatory that you have to have a 15 centimeter here also?
Let me insert, then come back. இது பிடிங்க. ட்ரொக்கரு அதை வச்சுக்க, இது வச்சுக்க, ஃபுல்லாக வச்சுக்க. அப்படி வச்சு ரைட். கேமரா போ. Okay, விட்டுறோம். Leave this. இது பிடிச்சிக்கோ. அம்மா புஷ் பண்ணுங்கம்மா. அதில் பண்ண முடியாது இல்லை. சரி விட்ரு. கொண்ட ட்ரக்கர் உள்ள புஷ் பண்ண. ஓகே. விடுமா, கொஞ்சம் விடுமா. मेरा कैमरा கேட்டு கம் தி சைட். எஸ், போங்க போ. அப் காட்டு. Yeah, now it is got locked. Okay. இதை பிடிச்சிக்க, இப்படி இதை பிடிச்சிக்கோ. அப்படி வச்சுக்க. கேமரா மேலே போ. அப்படி பிடிச்சிக்க. Come back, camera, come back. So here we have seen the line. It is docked and no tissues in between the all round. We have to check it. And better to keep 1 minute, then we'll fire it. And what you was asking that if you do pouch, what he said? Hello?
Sir, he was asking whether 15 centimeters is required. That part he was asking.
Huh? No. 15 centimeter is general rule, but lesser, sometimes even less, okay. Instead of no pouch, between 10 and 13, 3 cartridges we'll use it. That is better. But it even this jejunum has got a tendency for dilatation later, even a small little. But as a teaching, no, we will see 3 cartridges. That's why I kept 15, and each time fire 5. 1 minute, Achama. I will show that now. Huh? I fired. That thread must have been pulled up. Usually, after firing that, that other side will become flat when we are unlocking it. Yeah. That plastic tube, it goes to the plastic. Plastic pull pantingama. No, I think I have to clean it. It should go to the plastic tube and come back. Could you stitch it more? Ethyl and leather in the loan could cast close finishing. இதில் திக்க சில்க் இல்லைன்னா புரோலியனில் எடுத்துக்கூடாது அதில் போய் ட்ரை பண்ண நிற்குமா ஸ்டிச் எடுத்துட்டு போட்டுக்கலாம் புரோலியன் கொடுக்கலாம் எது வேணாலும் கொடுங்க இப்போ கொடுங்க அப்புறம் எடுத்துக்கலாம் லைட் ப்ளீஸ் அப்புறம் போட்டுக்கலாமா விடுமா ரொம்ப பெருசு This is temporarily I'm putting it, I will be taking out. Then I will finally close it nicely. Cut. Trocar. Trocar கூட அப்படி okay gas on stapler go in the போடு ஒரு லீனியர் ஸ்டேப்லர் நோட் பண்ணி வச்சுக்கோமா அவங்க இது என்ன வச்சிருக்கிறீங்க ஒயிட்டு தான் எப்படி வச்சுங்க செக்ஷன் this trim I will be taking off. Suck. Irrigation. இப்போ ஹெட் அப் பண்ணுங்க. விடுமா இரிகேஷன் விடுமா? ஓகே. Suck. Okay, stapler. Trocareluma. அப்படியே வச்சுக்க. Ball forces. இது எங்க நம்ம லெஃப்ட்ல கொஞ்சம் நல்லா ரேஸ் பண்ணுங்கம்மா. லெஃப்ட்ல நல்லா ரேஸ் பண்ணுங்க. ஹார்மோனிக். இல்லை இல்லை ஏறி ஊட்டுறோம் அப்படியே பிடிச்சிங்க. பிடிமா அது ஹார்மோனிக் இல்லை அதில் பிடிமா. ஓகே. ஐ எம் மேக்கிங் எ என்ட்ரி இன் த ஸ்டேபிள் லைனு. பிடிச்சிங்க. ஹூக்கு இது எடுமோ இப்போ பிடிச்சிக்கல. அது கொண்ட ஹார்மோனிக் கொண்டு.
As you are doing this, I only remember the isolated jejunal loop we used to take long back, and do what is called as neogastric reservoir, meaning the isolated loop will be made into not a J, complete U, and the
if it is we are used a linear stapler, J would have gone easily. No division. This need not be divided. And because it is going mediastinum, so we want to have narrowed the hiatus, and the reflex to some extent they can be minimized. Come iluma அப்படி இங்க வாடு. Camera here.
What I was trying to tell about neogastric reservoir is the isolated jejunal loop. The end to side will happen at the summit, and down it will be anastomosed to the duodenum, so that it will be a natural pathway, and it will be like an interposition. But after doing that, when we did swallow, we didn't find any reservoir effect. It just went through. So after doing half a dozen, at that time it was popular, so we did it. Then we stopped saying that you do it whichever way. Ultimately, reservoir function doesn't happen. It's only behave like a conduit.
இது வந்து differently we are taking 15 centimeter. Another anastomosis down I have to do it. ஸ்டேப்லர் கொடுமா.
ரெண்டு லூப்பே சேர்த்துறீங்களா சார்? ஜேஜே பண்ணுறேன்.
ஜே தான். அதான் பவுச்சு தான். இப்போ திஸ் இஸ் ஃப்ரீ செக்மெண்ட் வச்சிருக்கேன் பாரு. இது ஃப்ரீ செக்மெண்ட் சைட் டு சைட் பண்ணுறோம். This is this is a divided pouch like, because we cannot have loop into the mediastinum. நம்ம இழுத்து கொடுங்க.
ஒமேகா மாதிரி வரும். ரெண்டு வித் ஒமேகா போச்சு.
காஸ்ட்ரிஸ் கொடுமா.
என்ன இது கொடுக்குற மிரில் கொடுக்கலையா?
அவங்ககிட்ட இல்ல. அவங்ககிட்ட இல்ல. மேலே போமா, கொண்டு போ மேலே. மேலே போ. எது? keep like this. ட்ரொக்கார் இழுமா. இல்லைம்மா, ஓப்பன் ஆகல பாரு. மேலே போ, மேலே கொண்டு போயிருங்க. ஓகே, விட்ரு. அது விட்ரு, நீ விட்ரு, இதை விட்ரு. அது பிடிச்சி. ட்ரொக்கார். When doing is, we have to see the mesentery should not come closer. Hold this. White, 3 white கொடுக்கணும். கேமரா மேலே தூக்கு. இது பவுல் கொடு, பவுல் சர்சஸ் கொடு. ட்ரொக்கார்கள் உள்ள போயிருக்கு. அது பிடிச்சிங்கம்மா. இங்கே பிடிச்சி, இதை பிடிச்சிக்கோ. அப்படி வச்சுக்கோ. கேமரா கோப் கொஞ்சம் அப்படி தூக்கி. முடியுமா? விடக்கூடாது. இங்கே பார், ஹோல்ட் தீஸ். புல் ஜென்டில் புல் பண்ணும். Hold this. Come. Come back. இழுக்காதுமா இப்போ. Come back, come back. கூட்டமா இழுக்காதுமா இப்போ. இன்னொரு ஸ்டேப்லர் கூட. எஸ். ஒரு 20 PDS எடுத்துக்கங்க. அது ஸ்டேப்பிள் இல்லை முடிச்சு. ஏன் செய்து அப்படி. This slightly would have been reduced better, but still that loop will work like a neoesophagus like. Suture. This can be closed, suturing, or can be stapler also. I will show stapler. The other one I will show suturing. This set. Come on. அப்படி வச்சுக்கோ. ஹோல்டிங் கொடுமா, கவுடு கொடுங்களாட்னா. சரி சார். This is serosa injury is there. Either we have to suture it or the stapler would take it out together. Put your hand on, keep. Trocar, slide. Okay. Trocar. Up, up, up. இது ஸ்டேப்லர் இதே ஒயிட் போட்டு சி ஓ ரைல் ஸ்டூப் போடுங்கம்மா சிஸ்டர் ரைல் ஸ்டூப் பாஸ் இன் நீல் ஹோல்டர் இப்படி ரொட்டேட் யூ லீவ் இட் விடு ரொக்கார் இல்லைங்க hold this hold this வருதா ஓகே புஷ் 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 இல்லை கொஞ்சம் இழுத்துக்க ஸ்டேப்பில் போட்டு இழுத்து அள்ளிக்கலாம் இல்லை போதும் அப்படியே வச்சுக்கோ அது இது வேண்டியதில்லை அதுக்கு தான் இழுத்துக்கிட்டோம் கொண்ட ஸ்டேப்லர் கூட இல்லை வேண்டியதில்லை போயிடுச்சு மேலே போயிடுச்சு எங்கம்மா இல்லை விடு இங்கே விடு இது எடு கீழே பிடி அது எடு அது பிடிச்சிக்கோ இப்போ மேலே பிடி இல்லை யூ கண் ஹோல்டு hold this.
Sir, why this step, sir? This particular step?
Pardon, I'm just, instead of suturing, I'm just put a stapler showing it.
Right.
The other one
you already sutured. No, you only just...
No, just stay sutured.
Yeah, I got
I'm not perfectly closed it.
It is more of an approximation to pull it up. Okay.
Yeah. And I just I made it a 3.
I got it. Right.
Yeah. But now rails to pass in. மேலே கட்டு. It has come here, so we can start feeding now from tomorrow itself, and if I pass beyond the anastoma. Okay. இன்னும் கூட தள்ளுமா கொஞ்சம். Okay. Right, Paul. அம்மா பவுல் கிராஸ் பண்ணிடுமா. Okay, hold this. Harmonic. Ball purpose. And here we'll take at least 5, 10, 15, 20. Okay. Hook kaduma. Hook இருக்கா? மோனோபோலர் கால்கிட்ட வைங்க. What this? ஆன் பண்ணுமா? Stapler. Trocar outside. Leave it. Up camera. அப்படிமா அப்படியே இல்லை பரவாயில்ல அதில் மாட்டாது.
The rails tube is very close there, so that's all.
கொஞ்சம் புல் பண்ணுமா? இல்லை
It's on the side.
Yeah, it is okay. பரவாயில்லம்மா போட்டு. Get a 20 PDS. longer, so as need to be closed, one can take a V-log. 3-0 particularly is good for this suturing. And if it is short, I think it is costly. You need not waste it. I'll put it this one stay like, then I can come from other side. உள்ளதா உள்ளதா உள்ள போ. See, sir. See, sir, nail holder. Trocar out. Wait, mutter. எங்கப்பா லாக் ஆகலப்பா நோ லாக் scissor. Nail holder. ரொக்க ரெடியூசர் மட்டும் வெளியில் பிடிச்சிங்க. கேமரா தூக்கு மேலே தூக்கு. The falcium ligament this side all the time hitting. நீ ஒரு ஸ்டெப் அதை ஸ்டெப் பிடிக்கிறியா சிஸ்டர்? ஒரு ஸ்டெப் எடுத்துட்டு அப்படி பார்க்கல. இல்லை கவுட் எடுத்து போடும். அது இல்லை, இது பிடிக்கணும். அது இல்லை, இது இப்படி எல்லாம் சரி. இதான் பிடி பரவாயில்ல. நீ இது கிட்ட தேயில பிடிமா, நீ இது டிப்பை பிடிச்சி போதும். This suturing also, if you put a stapler standing right side, would have been easier. Generally it is goes, but this one suture need not change. விடுமா. அப்படி வச்சுக்க.
So that instrument has gone above the loop. So that holding instrument has gone above the suture material.
Yeah. இல்லை, too much no here. It's okay.
It's okay.
It's little more, and that holding it both stay, and these must be like this.
Yeah.
If it is stretched out, it is better. No instrument. அட விட்டுமா பாரு அப்படியே வச்சு. அப்படி வச்சு அப்படி வச்சு. இரிகேஷன் எடுத்துங்க. Okay, scissor. Crocodile. Irrigation.
Sir, it has come out very well, sir. The pouch as well as the closure.
This suturing I did not, for me, but position somewhere that it's not comfortable to do.
That's it.
I think it is okay. I'll
Yes.
Irrigation. Head down, please. Head down, Panama.
Sir, now that
Down, left side
the
out.
pouch reconstruction, everything is over. I seek your permission to leave, sir.
Pardon?
I would like to leave, sir, now. I
Yeah.
will go for another meeting.
Thank you. Thank you very much. Air Purma.
And for my knowledge, how are you going to retrieve from where you are going to retrieve the specimen, sir?
I'm going to suprapubic peninsula.
Right.
That is for every specimen. Our standard is removed
Right.
there.
No.
Yeah.
For the sake of everybody, I asked.
Yeah.
Thank you very much, Roshan.
Yeah.
Thank you.
Thank
Sir.
you.
Yeah.
Okay. விட்டுருமா விடு போதும். இப்போ இங்கே பாரு இங்கே காட்டுங்க. இப்போ இரிகேட் பண்ணு. இப்போ இரிகேட் பண்ணு ஒரு தடவை. போடு.
So are you doing a leak test here?
Yeah.
Okay.
Sir. Okay. That is fine. Thank you.
Yeah.
I will have to narrow the height is making it up. யார் எடுத்து விட்டுருங்க. I thank everyone for today making it.
It was a wonderful demonstration, sir, as usual, as expected. So, it was a wonderful demonstration. As expected.
Oh, thank you. And I think it is.
I learned.
Thank every moderator and the participant also today. And all of you discussed very well about the issues. Next, actually today planned for esophagus only, and then we change. Next month will be esophagus. Let us have that prone esophageal A to Z. That suck.
And the transition was wonderful. Congratulations to Parthasarathi and his team.
That they knew. Head up panuma. Cut.
There's an umbilical tape next to the afferent loop. Just beneath that. Down.
அப்போ வாங்கியிருக்கணும் மூலமா
கீழே இருக்கு சார், கொஞ்சம் கீழே இருக்கு சார்.
இல்லைப்பா
இங்கே கீழே இருக்கு சார்.
So the total login was today is 574, sir.
Oh, wonderful! Congratulations.
575 login from the beginning. It is not due; it is a login. So maybe some place
less than what you see.
எத்தனை வாங்கிக்கலாம் இது எடுத்து பார்க்கலாம். முடிச்சிட்டோம்னா then we'll check it. அப்பவே வாங்கிருக்கேன். அல்ல அது ஸ்பெசிமென் கூட போயிருக்கும்.
I think the lateral aspect of this loop, this jejunum is there. Down.
Umbilical tape, sir.
இந்த JJ சைட்ல சொல்றாரு சார்.
Yeah.
JJ சைட்.
Ball for self. Reduce report to pitching madala. Pitching reduce it.
Yes.
Scissor. Proper. Proper ill. Huh? Time என்னமாச்சு?
6:15. RA calls.
Okay. No, I have to go to airport. That is asking. Tomorrow, Delhi, there is a robotic meeting.
Sir, can you show me the loop, sir, that so that I can draw a picture, people can understand better.
In the loop,
Entire anastomotic loop. The wide one, the camera to become wide.
Understand now? Lift up camera.
Yes, sir. அப்படியே வச்சுக்கலாம் சார். இல்ல மூவ் பண்ணாம இருந்தீங்கன்னா I can draw and then I can.
Okay.
So this is அப்படியே வச்சுக்கலாம் சார். மூவ் பண்ண வேண்டாம் சார். கேமரா வைடு மேல நான் அந்த ஈசோஃபேகஸ் காமிங்க. பவுச் இல்லாம அந்த ஈசோஃபேகஸ். ஓகே. வைடு கேமரா கம் அவுட் some more out. Okay. So this is this act like a neo esophagus. Come down now. So this is the pouch. Pouch 15 centimeter. How much length, sir? The pouch?
15
centimeter. So this is the intracorporeal J pouch, 15 centimeter with free
isolated
free jejunal
and that room construction beyond that.
Yes, sir.
Here.
This is the JJ pouch.
Yeah.
The JJ, not J pouch. JJ.
Yeah.
Side to side jejunal. Okay, sir.
Liver right side. நாட்டு பிடிக்க முடியுமா? So beyond it is abstract, no? It is okay.
Yeah, it is optimum.
Generally, gastrectomy, no need for drain, but this cases we need total gastric.
Yeah.
இல்லம்மா
So we
That umbilical tape has to be removed, sir.
try to trace
irrigation.
Below
I have to take it out. I think it is by the specimen. See, this is a very falcium ligament making me a problem. I put in a bag, then I will irrigate thoroughly. We'll take.
Wonderful once again, sir. Congratulations for the great show.
Irrigation. Sir.
Thank you, Roshan, for the invitation.
Thank you, Raju.
So let me log out.
இப்போ இடையில போட்டு எடுக்கலாம் சார், இல்லை வேறு கடைசியாக போட்டு விட்டுலாம் சார்.
Sir. Okay. Ball forceps. பேக் கொண்டாமா இதில் வந்துச்சு பார்த்தீங்களா? ஆமாம், புள்ளின்னு எடுத்து இதே வந்துடுச்சு. This is it was lying there only, and the colon and the great omentum, and there is not great omentum is not there. Colon must pull to the right side, because the low down is cardally, and that is why. And I think no need for closure. Okay. Pendle. Needle holder. Back கொடுங்க. Any size of the bag can be placed after moving the trocar. The lift up. மாற்றி கொடுக்குறேன், இதெல்லாம் முதல்ல கொடுக்கணும். இல்லைம்மா, மாற்றி கூட கேஸ் பீஸ் வச்சு வைக்கலாம்ல. ஓகே, கேஸ் போடும். புரியுமா? You also hold it there. ஆமாம், கொஞ்சம் மவுத்தை நல்லா பிரித்து விட்டு பழகின என்ன சொல்லி பார்த்தாலும் பண்ண மாட்டேங்கிறீங்க. நல்லா விழுத்து ஓப்பன் பண்ணலாம்ல. இல்லை அதில் நோ திஸ் ஒன். யா, ஓகே. இதை விட்டுருமா, அங்கே விடுமா, இதை பிடிக்குமா? எங்கே பிடிச்சிக்க, இதை பிடிச்சிக்க. Okay. You.
So is there any momentum left behind, sir, near the hepatic flexor? கொஞ்சம் fat.
Which one?
Hepatic flexor கிட்ட கொஞ்சம் fat இருந்த மாதிரி இருந்துச்சு. So momentum, free momentum மாதிரி near the
இல்ல.
அந்த கலர். ஓகே ஓகே.
இல்ல அது டிசைட் பண்ணது.
ஓகே ஓகே. இல்ல சார்
இல்ல. அது எதுப்பா? ஸோ நீ இன்சிஷன் போட்டு இது எடுத்து ட்ரெயின் வச்சிரு. Okay, thank you.
Thank you for the wonderful demonstration.
Yeah.
I request Venkatachalam sir to show the next month's flyer.
Okay, Roshan and Varghese, all expert panel, and I'm taking leave.
Thank you, sir. Thank you, sir. Have a safe journey. And this will be the next month's live program where sir will be showing a laparoscopic esophagotomy with lymphectomy. Sir's
வந்து அவுத்துடுறது தானே அவரு கையில தெம்மறிட்டு இருக்காரு.
So we have a distinguished panel of panelists. You can see the names. So
it is on 15th February, 3 o'clock p.m. Indian time. Okay.
Yeah. Thank you very much. Thank you, Partha.
Okay, sir. Thank you.
Thank you.
Thank you.